So ladies and gentlemen, we will go ahead and start our afternoon session. And for those of you who made it back at the 1:30 time, I want to thank you for having been here. We could hear crickets at 1:30, I have to tell you. So miraculously, our attendee group has reappeared for our afternoon session. And thank you for being here. So I'm very excited to start us off for our afternoon session for Nursing in 3D, Workforce Diversity, Health Disparities, and Social Determinants in Health. We have a fantastic afternoon session for you. I hope you had a second to stop by the poster sessions next door in Salon D, right next door. You'll have an opportunity to visit them again this afternoon. And by the way, there's going to be a vote on the best ones. So certainly I encourage you to visit them. So the panels, we're going to have two panels this afternoon. They are world-class. Our moderators and our speakers are tremendous. I'm going to introduce them to you. The two that have not been introduced have not yet been introduced. The group is already familiar with Dr. Braveman. I'd like to acknowledge on the podium here, and Dr. Malone. And in a moment, I'm going to ask you for a HRSA welcome to our moderator, Dr. Alexis Bakos. And Dr. Bakos is the Deputy Director for the Division of Nursing within the Bureau of Health Professions at HRSA. Dr. Bakos assists in managing the overall operations of the Division of Nursing and coordinating activities between the two branches and the Office of the Director. Prior to her appointment at HRSA, Dr. Bakos served as Chief of the Diversity Training Branch within the Center to Reduce Cancer Health Disparities at the National Cancer Institute. She coordinated the management of programs designed to improve the diversity of the cancer research workforce through training, career development, cancer education, and community education. And next to Dr. Bakos is Dr. Mark Nivet. And Dr. Mark Nivet is the Chief Diversity Officer for the Association of American Medical Colleges, where he provides strategic vision and programmatic leadership around diversity and inclusion. Through his advising, lectures, and writing, Dr. Nivet works to reframe the narrative around diversity. I personally experienced that at his presentation at Diversity Doctor 2011, and he's also speaking at Diversity Doctor 2012. Dr. Nivet works to reframe the narrative around diversity, positioning it as a driver of excellence and highlighting the link between community engagement and health equity. Their CVs go on and on, but I want to acknowledge our whole panel here, Dr. Malone, Dr. Braveman, Dr. Nivet, Dr. Bakos. And also there was some feedback that there was a feeling of too many physicians who were presenters. And I want to point out that Dr. Braveman is the only MD we've had so far on the podium. Most of the folks here are PhDs in nursing, nursing faculty, and of course we're happy to have Dr. Braveman here as a physician. But there are quite a lot of PhDs here. So please, I'd like to ask you to please give them all a HRSA welcome back with a standing ovation to acknowledge them being here. We're going to have a fantastic Q&A. Now that's some good energy to start with. So welcome back. And afternoon sessions right after lunch are challenging. So we've set this up for an opportunity for participation, audience engagement. Dr. Bakos is going to be in the role of moderator, in which she'll be moderating the discussion, which will go until 2:45, I believe. And Dr. Bakos will be in the role of moderator. I will happen to be in the audience. I'm more an audience representative. I won't be making comments on issues, but I'm there to facilitate some discussion. I'll be reading note cards. I already received one. Twitter comments. And of course, you're welcome to use the standing mics. And if you have anything you need to share, you can grab me. I'm really your audience rep. Dr. Bakos is the moderator for our presentation, this first panel this afternoon. So please, again, welcome our esteemed panel, and I will make my way off the stage. Dr. Bakos, your mic is on the table. Your mic is on the table. Yes.
So I think what we're going to do to just kickstart this panel here is that we've invited Dr. Nivet to come to the podium or sit and to sort of give a synopsis and sort of his overall impressions of the presentations from our first two speakers. So, Dr. Nivet, if you can kick us off here.
Thank you so much. Good afternoon, everyone.
Good afternoon.
Yeah.
It is wonderful to be here. When I first got the invitation, my first reaction was 3D. Why didn't I think of that title? That is such a brilliant title. And I think this morning, we certainly have lived up to that brilliance. Some of the things that I think a lot about is the sort of interplay between the social determinants of health, diversity, and the resulting health disparities. And I do think that there is a connection. I think we can talk maybe later, or maybe even tomorrow as I sort of close out, more about the evidence that exists to prove or disprove that connection. I think there's still some debate out there. But I think what I'd really just like to take a minute just to share with you, because I really want this to be interactive, as Dr. Swift mentioned, and not take time to cover a bunch of issues that I'll be able to do tomorrow. I just want to say that, I got my start in the health profession 18 years ago now, and I got my start on a HRSA grant. So I was funded I was a very young age, let's say, and I got started, and it was HRSA who got me started in this field. So it's really an honor and a privilege to come back almost 18 years ago and still to be affiliated and to still have these wonderful positive feelings I have about HRSA, and the work that you've done for 30, 40 years really needs to be applauded. So I'm just grateful to be sitting on the stage and be part of working with the folks here at HRSA as well. So all of that said, about a decade ago, I mentioned this earlier to a group I was having lunch with, HRSA invited me, hired me, I guess, to sort of grade the evidence on some of their pipeline programs, their health career opportunity programs. I don't know where that report is. I handed it in, but it hasn't come back out of HRSA. We'll have to talk about that. But that's part of what sort of my comments are today, and what I hope we'll have some discourse on, is that when it comes to sort of effective interventions, whether it's, eradicating those health disparities, whether it's increasing the diversity of the workforce, we don't have good evidence of what works. And in fact, I've been in this role for 2 years, and I've been to 42 campuses across this country, 42 medical schools actually. And I'm often struck by there's some person, some office at that institution that is doing phenomenal work, that has great evidence, but when I walk across the street to the nursing school, the dental school, any other health professional school, they have no idea what the medical school is doing. So the evidence is not translating within an academic health center. And so we're all still working in these silos across the country. And what I hope we can get out of this particular meeting, and I know our focus is nursing, but what I hope we can begin to do is to understand that the more we talk about social determinants of health, the further we go back in terms of the pipeline, we start talking about K through 12, you can't talk about this as an isolated health profession's efforts at eradicating those things. We need to bring together in an interdisciplinary fashion our thinking, our intelligence around solving these seemingly intractable problems. So I hope that over the next few hours we have together today and tomorrow, that we can remember that this is not about nursing alone, this is not about medicine or any other health professional field, this is about us. And this is about those patients. And if we do the same thing we're asking for broadly in healthcare, which is to remember, if we're talking pipeline, it's student-centered. If we're talking about healthcare, it's patient-centered. What we need to do is to put those individuals in the center and wrap our work around. And I think we heard that through the presentations this morning, that this issue is so big that there's room for all of us to work collectively to solve these problems. And I'll stop there, and hopefully we can engage in a wonderful dialogue. Thank you again for having me.
So one of the things I think I'd like to do before we sort of have a more broad dialogue, is we really weren't able to give Dr. Braveman an opportunity to maybe address some questions that you might have had. So for those of you who really wanted to be able to address some questions to Dr. Braveman, I'd like to take a few moments right now, and those of you, if you can either come to the mic or pose a question on a card that Patrick can pick up, but I'd like to see whether or not we have any questions for Dr. Braveman.
And you can tweet those. You can tweet those questions as well.
I actually would like to ask Dr. Braveman a question because one of the things that is very near and dear to my heart is pipeline programs, as Dr. Nivet also just mentioned. And one of the things, Dr. Braveman, that you spoke about was about those experiences very early on in childhood, on being biologically embedded. And one of the things that I am always very concerned about and interested in is when we're trying to get individuals interested, we're trying to develop pipeline programs, and we're trying to reach back to high school, middle school level, or maybe even say at the elementary school level. One of the things that we're always struck with is when Congress and our federal agencies, oftentimes directed by Congress, are asked to target funds for special programs, certain initiatives. One of the things that we often run against or come up against is, well, if we create these programs that are pipeline programs and targeting to reach to individuals at sometimes the earliest ages and getting them interested in health professions or in nursing, how do we really know that those kinds of interventions are really going to pay off in the long run? We often know that we may not necessarily see the immediate effects of those activities, and sometimes Congress running on fiscal year, or the federal government working on very much a fiscal year mindset, oftentimes when we appropriate monies, wish to see immediate results. So one of the things that I'd like for maybe for you or for the panel to address is, how do we balance that out, that need to see immediate effects from the dollars that we appropriate, yet knowing that from the earliest years of an individual's life, we need to be having some kind of an impact. So if you or the panel could address that, I would love to hear your response.
Well, I'd be happy to start off addressing it, and then really happy if I could hear Dr. Nivet and Dr. Malone's take on it too. I think you've put your finger on one of the most difficult issues, that an investment in early childhood is probably where the payoff is going to be the most, but you're not going to see the effect maybe for decades. And decision making is not done that way. I mean, for Congress, it's 5-year window for evaluation. Maybe at times they'll talk about a 10-year window. That's not enough to see the effect of investments, certainly in really early childhood. I think we know that we always have to balance between the short term and the long term, but I think that there's an education that has to go on, an education of the policymakers to realize that some of the most impactful investments that are needed are ones that we're not going to have the data right away. One more thing that I'd like to say about this, I think we're all trained. I mean, if you're in medicine, nursing, well, the gold standard for the proof that something works or doesn't work or has an effect is the randomized clinical trial. Well, if you think back to those, I showed you those 3 busy charts on different ways that education could influence health, and all these steps in between, and they were really, each one of them was a gross oversimplification. and all of them happen. It's not, you know, that there's just one and not the other. And some of them play out over one lifetime, and some of them play out over generations. You're not going to be able to do a randomized clinical trial of the effect of education on health under those circumstances. And we have other techniques, I think, that enable us to be pretty rigorous in looking at effects. We're going to have to educate ourselves so that we don't get shut up when we, I can remember being in a situation myself with that commission that I talked about, the Robert Wood Johnson Commission to Build a Healthier America, and I was heading the research arm, and one of the commissioners turning to me and saying, well, how good is the evidence on that? Some issue had come up in their discussion, and I felt paralyzed initially because of my training that if it's not from a randomized trial, then it's not evidence. So some of it is, it involves an education within the health professions about that, because we're not going to have that kind of evidence on the social determinants of health. And yet, when you connect the dots, you say that's where the payoff is going to be the biggest from an investment there. Do you have any?
Well, I'm thinking about the NurseFamily Partnership work. That's been a study that's been going on for 20 years, and that is based on a randomized blind study, control study. Three of them, as a matter of fact, and where they really did come up with data that say that if you send a nurse into the home of a underrepresented mom in terms of socioeconomic status, it doesn't have to be race and ethnicity, and that nurse works with that mom who's a new mother, that the two of them and the family can make a difference in the lives of that child, not only in the lives of the child, but in the lives of the mother. That the mother will tend to get more education, that the child will tend to have more education, that there's a decrease in juvenile delinquency. I mean, the data are there. So my thought is, we all can't do the same thing. And I really like what Paula is saying in terms of that there has to be some of us to do some things, and there has to be some of us to do other things. And I think when you get to a model that says there's only one way to do it, that it has to be done this way to be solid evidence, that's where we get the problem, and that it's broader than that, and we need to bring that to the table. And I think that's what we've been doing as nurses, bringing it to the table, that there's more than one way to skin that particular research cat.
In regard to that, there's a comment, Dr. Malone, to the group that there's a tweet, pipeline programs, by their very nature, take a long time to show results. How can we show Congress that funding them is worthy? And that touches on how do we prove it? How do we present that data? And Dr. Malone, on a comment for your presentation, an attendee wrote, Dr. Malone's speech on how racial, ethnic disparities disappear or are greatly reduced after controlling for socioeconomic differences is like the movie Trading Places. She writes, it's like the movie Trading Places where behavior changed by having financial means. One comment from one of our attendees.
I couldn't hear everything you were saying.
Oh, really?
I'm sorry.
That kind of validates what okay, so one tweet was, I'll move a little further over here, but one tweet in regards to having data to back up this need. Someone tweeted, pipeline programs, by their very nature, take a long time to show results. How can we show Congress that funding them is worthy? So the challenge of proof and data. And there was also an attendee who wrote on a card, Dr. Malone's speech on how racial, ethnic disparities disappear or are greatly reduced after controlling for socioeconomic differences is like the movie Trading Places, where behavior changed having financial means. The character Ralph Bellamy and Eddie Murphy Trading Places.
Yeah, I remember.
One comment from an attendee.
Since I am the moderator, I'd like to hear from our audience. So, Dr. Powell.
Dorothy Powell, Duke University. Dr. Braveman, thank you very much for your very, very in-depth evidence-based presentation. I found it very helpful. You talked about environmental toxicity. You talked about stress. and you talked about the contribution of that to chronic disease. So my question is, can you just briefly share with us what the evidence, the variety of evidence, is saying about the kind of interventions in workplace environment relative to this whole notion of toxicity, its impact on stress at all levels of people working in that environment? What are some of the things that settings such as that could benefit from?
Well, that's a great question. I'm sure there are other people in the audience, if not on this panel, who are great resources on that. You know, the evidence is spotty about the interventions. That's where we're generally weakest, except that we have, and this was alluded to, we have the strong evidence about about early childhood interventions like the NurseFamily Partnership, but also like high quality early Head Start type programs. There we have really good evidence about the interventions, and it's spotty elsewhere. You mentioned the work environment, and I know that there's an area called what is it? They even use the word justice is in organizational justice as the rubric, and that they have seen that they have done interventions in workplaces that have actually improved productivity while at the same time improving workers' well-being through giving people more say, and that's just an example. This relates to one of the tweets that Dr. Swift had read about how do you back to this question of, well, how do we get better data, knowing that you're going to have to say something to a funder when you have a long-term outcome. And I think the key there is that we think through sort of logic models for everything that we do. What are all the steps? And then say, which of these intermediate steps could I actually measure, and refer to that logic model and back up the inferences with literature at each point. And I think that if we take that approach, that we will we'll go into the funding arena a lot better armed. But it is true that there's very spotty evidence, and some of it is, as Dr. Nivet mentioned, there is a lot that has been done, but it hasn't necessarily made it into the published literature where you could find it, or there are studies that have been published, but they're weak in certain ways, which they didn't need to be if they had the consultation and support when they were designing and studying it. So a long way to go in the intervention literature, but we can't shrink from it.
Hello, I'm Sandra Benavides by Washington State University College of Nursing. Dr. Braveman, these questions are for you, and if you could say they're great even though they're not, that would really help my self-confidence in public speaking. Okay, so your discussion really resonated with me when you were talking about framing disparities almost around human rights. And some of the challenges that I face as a faculty member and also as an individual in the community is, how do you talk to students, policymakers, and just the general population about understanding that minority groups such as Latinos, which are now majority groups in numbers in, say, Texas and in other areas, how do you get individuals to still understand that these are an underserved minority group in terms of disparities, et cetera? So that's one question. I have another one if we have time.
Well, that's a question that I would bet that my co-panelists could answer at least as well. I think we have to get the concepts out there and an understanding that, we're talking about people who've been marginalized, who've been excluded, who've been the objects of discrimination, and it's not, the evidence is there. that Latinos, if you're talking about those criteria, that Latinos qualify. One of our problems in talking about human rights in this country, though, is that we've had this attitude, it's called American exceptionalism.
Right.
So sometimes talking about international human rights can backfire. People say, well, that's for those other places, that doesn't have anything to do with here. I think that is such a disgrace. And we need to make sure that these issues are being discussed, and that kids are getting an education, that we're talking of having the discourse about values and these concepts is happening in the public. So I don't know.
What I was thinking of is, I don't know if you've ever been in a room where there's a discussion about whether or not the minority of the day is really needing the services. And you're looked at, especially if you're a representative of that group, as the expert, and as the one who should speak for all of your cousins and brothers, and they think you're all related. There's, when you're a professional, there becomes an additional burden. Talk about toxic stress. My colleague over here, Dorothy, there's a burden that feels like it's on your shoulders as to how you address this. Remain in your professional role without bringing so much of your person into dealing with the issue, and that is very difficult. And so you need some colleagues. You need somebody else to bring up the issue besides you. You need to appoint, assign, delegate one of your supposed good friends to have something to say about it, so that not every time it's you who is answering and feeling that incredible pressure to remain professional and at the same time speak on behalf of the people and your family and all of those, like I said, brothers, sisters, and nieces.
Thank you. Is there time for the second question? Do you want me to wait?
Sure.
Okay. My second question is, our intervention studies that focus on health education in relation, or self-efficacy, self-agency, etc., or clinical studies are funded, and then these findings are sort of what help us to develop our evidence-based practice guidelines, etc. But they're done often without the context that we've been discussing before, which is, the social economic issues as well as, life experiences. And so how do we then, do we need to address this? Do we need to make future studies, funding happen? Yes, we want you to look at health education around diabetes, but you need to do that within the framework of et cetera, because I don't know that necessarily happens right now, and I think funding is either we want clinical trial on this, but it doesn't really look at the whole package, and so then how does that help further improving or reducing disparities? That was it.
I'm not sure I understand the question.
It's another great question. I mean it. Yeah, it's like the model for science that we're all you just manipulate one variable, right? And everything else gets held rigid. Well, in case you didn't notice, that's not the way the world looks. And, and I think the person who is trying to bring in the awareness of context is at a disadvantage. It certainly with NIH, or has been. Less so with the foundations, but still, the funder is going to look at, well, what's the publishable product that's going to come out of it? If they're coming from that point of view, then they're up against the journals, And I think we need to strengthen the science of studying social phenomena. Because the fact that we can't do a randomized controlled trial, and that should mean, therefore we say, okay, I just throw it all, I'm not going to try to be scientific, I'm just going to try to be moving, or, we have to have the science there. But I think I see signs of this developing. a science that is better able to look at context and techniques, multi-level modeling, where you're including variables at the community neighborhood level, also at the individual level. I think there is a lot. It's slow. It's not enough. But education within the professions about the existence of techniques and ways to be rigorous without doing an RCT can go a whole long way. But yeah, randomizing areas to different interventions is, to get that. And you could randomize at the area level, but then you'd still have all these variations on a theme of the individuals.
Let me just take a second to amplify one of those points. And I think that it's not the funding agencies or the private philanthropic organizations that are not asking you to innovate. I think that there's a lack of capacity within our existing infrastructure to appreciate the different fields that exist, the social science literature, and bringing those to bear on all of our work, whether it's in medicine, nursing, any of the health professions. So I think the onus is on us. I think that I've seen in the last 5 years a shift in funding opportunities that is asking us to be more collaborative, asking us to be more generative and open and innovative in our approaches. And what I've seen coming through and I happen to also review grants for NIH, and I'm on the advisory board for NIGMS, is unfortunately pedestrian approaches to research and not many novel ideas coming from the field. And that doesn't mean that they're not there, so don't misunderstand what I'm saying. But we haven't yet, I think the research community out there have not gotten closely aligned with the practitioners on the ground doing the work so that they could come together and begin to submit some innovative, practical, rigorous scientific research. So I think we all have a lot to do out there in the field too. I don't think it's just the funding, the calls for proposals are limited.
Thank you. Debbie Greenwald from Alvernia University. We recognize the challenge of needing demonstrated outcomes, to solicit funding for these programs. But as Dr. Malone said, we have the NurseFamily Partnership Program with a track record of good results. There's a history of evidence there, and yet, I don't know about in your all's part of the country, but in Reading, Pennsylvania, my colleague at the NurseFamily Partnership, every year her funding is in question, and every year she has to beg, borrow, and steal for almost everything. And so I'm wondering, what do we need to do to take that evidence that's there for a program that's working and make it sustainable so that these people doing good work at the community level don't wonder every 365 days, are we still going to be here next week? And I say this with caution. I don't want to offend anyone in this room at any level, but I wonder historically if it's to some extent with that program, because we haven't yet seen the culture shift at the top levels of the funders that recognize nurses as doers and shakers and conduits for that positive change. And if it was physician-family partnership, if it might be funded a little bit differently, do I dare say. And so I don't know that. I don't have the evidence for that. So I don't mean to alienate anyone. I come from a family of physicians and nurses, but I sometimes worry if it somehow is because it's a nurse-family partnership and people think, oh, what a good program. Well, they'll just beg, borrow, and steal for everything because that's what nurses do. We make it work no matter what,
Well, there's some good news. And the good news is that NurseFamily Partnership is in 49 states now, and looking to expand itself even more. The monies for that have been, the initial monies were put together by about 7 big funders, and I don't have all the names in my head, but the ones that you know to be the big funders, the Kellogg's, the Robert Wood Johnson's, the big funders, to get it out of the research labs and into practice. And it only went into practice about 10 years ago. So it was just research before that. And I think that the problem, the opportunity, I won't call it a problem, the opportunity we have is how to get our local funders involved with our states, involved with our local communities in supporting public health. Because basically that's what NurseFamily Partnership is good public health. And I think I'm so pleased that it is a nursing-led initiative, because I believe it helps nursing to reassert one of the basic roles that we've always had of working and coordinating care within the community. And yes, I don't know if it was physician-nurse partnership, well, that would be kind of neat. Nurse-physician partnership, that would be called collaboration, I think. But in many ways it is, because the nurse who's leading that works with all the different provider groups, whether we're talking social workers or physicians or pharmacists, but to bring the services and to help that family member, that pregnant mom, and in the first 2 years of the baby's life, to actually learn how to leverage resources, how to access resources. So I think we're farther ahead than indicated. And I just think we have to keep focused. Don't take your eye off the prize.
Okay, my name's Suzanne Ganyan. I'm a family nurse practitioner and a doctoral student at the University of New Mexico. And I'm lucky enough to be here this summer actually doing an internship at HRSA. So it's been really an honor. And I just wanted to make a comment on kind of thinking outside of the box as far as healthcare professionals and addressing social determinants of health. I have done my clinical in the last couple years. I've worked at a school-based health center. I do adolescent medicine. And first of all, I just want to make a plug for primary care in schools. There is no better place to provide medical care, especially for adolescents. So I just want to put that quick plug in there. But I'm also on a school health advisory council. So all of a sudden I'm learning about school boards. And I'm very interested in the interaction between education and health. And there was a piece in a prevention, disease and chronic prevention magazine 2 years ago with public health people saying, hey, if you just graduate people from high school, we'll have healthy adults. You know, and I thought, well, that's an interesting perspective that, you know, the public health people are saying we don't need to do anything but graduate people from high school and we'll have a healthy population. So there's an organization, so we know if you get an education, you're going to be healthier. We don't need to create that evidence. We know that. So there's an organization in New Mexico called Appleseed, and they are looking at educational disparities. And they did a project, and it's called The Same Starting Line. And they compared high schools in New Mexico and other parts of the country and looked at number of times the principals were removed from and changed, that the faculty change, where they're switched from school to school. They looked at how many children were tested for gifted. So in the high school, and my children are in the Albuquerque public school system, not at this high school. They chose a high school in a very low income part of Albuquerque. And at that high school, New Mexico is a Hispanic majority state. The number of Hispanics that were tested, students that were tested for gifted, way lower than any other of the other high schools. Okay, so here's your social determinants right here, the starting point. What is happening in schools? So they looked at, like I said, how many times the principal gets changed over. So all of those things, if you think, well, okay, it's not really related to health, it is so related to health. If those kids aren't gonna graduate, and I know we have some school nurses here in the room, they came and were paparazzi at our table. Hi. So really heroes on the forefront. They see it every day in schools, what happens with inequity. The only other comment I want to make is there's also a parent organization in Albuquerque called Families United for Education, and they've spent 2 years, have been peripherally involved, trying to get a family engagement policy that is about equity for students in the school system, and it's been very interesting to see the board resisting this. They had 400 parents contribute to this policy. So when we're looking, I just want to, just kind of bottom line, when we're looking at policy, health, social determinants of health, the cross between the education and health is just invaluable. So take time and go to a school board meeting and, lend your voice.
Hi, my name is Linda Taylor. I'm Dean of Nursing, founding dean at College of Menominee Nation, and a proud member of the United Nation of Wisconsin. My question is to the panel. It was a little disconcerting to me that there was not a lot of Native information that was available to some of the data that was presented today. My deepest concern is that that data is used for resource allocation, and I was wondering about the impact on what are the barriers to the data being collected. Are those barriers being addressed? Thank you.
I didn't do a presentation, but in terms of, I'll just speak for the AAMC. So we've been collecting information for decades, and unfortunately the data is showing that we're not increasing the numbers of Native American individuals in medical schools. For the last 40 years, we have not made an increase. What we've talked about over the last 2 years is sort of doubling down our efforts in particular states that we know have high population of Native Americans. So we're working closely with a group that's just come together called the Four Corners Alliance, which is Colorado, New Mexico, and whatever the other two corners are, Arizona. That's right. And so what we're really looking at is exploring innovative models of engagement from K through 12, but also not limiting, or K through 16, but not limiting our conversation to pipeline, but what is it about our institutions and our policies and our admissions processes that are impeding progress in terms of increasing the number of Native Americans in medicine. So we're in that stage of deeper investigation, deeper commitment, and now we're trying to formalize some memorandums of understandings with a few of the Native American nations out there. So this is all a work in progress, but we recognize we have been woefully inadequate in our attempts in the past.
And I would just say that nursing is in a very similar situation, except I know that it's like about 0.8%, so in terms of the representation, which is lower than 1%. So sometimes that's
0.6.
That's what I'm sorry. Thank you. 0. And so I know that that's sometimes discarded as unusable data, but I think it's very important and very significant, especially when you talk about health disparities. And
allocation of resources.
Well, you know that better than I do. And so I think it's something that that's one of the ways you keep us. That's what we do. That's who we are. We need to advocate for that, and you're totally right, on target.
Excuse me, before you sit down, please don't sit down yet.
I just wanted to
certainly
add something to that. This is a great example of where if you don't have equity explicitly on the agenda, it makes no sense to put out the resources that you're going to need to collect enough information on American Indians in order to be able to make sense out of it. It's only the commitment to equity
Correct.
that would lead you to
it's
say
the barriers that need to come down.
That it is going to be more expensive because it's a population that's dispersed. There aren't large numbers of people in any one place, and I know, for example, in our maternal and infant health survey in California, we don't get enough American Indians in the survey. Every year we've tried to raise funds to do an American Indian specific version of the survey where we'd go out and get try to survey every American Indian in the state. We haven't been able to raise that money. It's a lot more expensive per person than it cost us to do the survey with the rest of the population. But it's an equity issue.
Hi, thank you for not sitting down yet. Since I'm the moderator here on this panel, and also since I'm deputy director, I would like for you to have to pose an ask of me, Tersa. So what comment or what is it that you think that we need to be aware of or that we need to be doing? I'd like to hear your comment.
Well, some of the allocation resources that have been structured to provide education for Native American nurses, specifically in, I'm a little nervous here, specifically in like universities and stuff like that, have been geared towards taking Native Americans out of their home, out of where they are comfortable, and putting them into a university, a medical college, someplace else, and that is very difficult to do. There are some places that do it and do it well, but for the most part, I've twisted that a little bit, and I want to provide education on the reservation, as opposed to pulling them off the reservation. And it's a different way of thinking about it, but that's just my own personal comment. I'm having some success with it. It will take generation. I think some people need to come up. I think the pipeline is very important in my little own microcosm of the world. So that's what we're working on, is laying the foundation to pull people into nursing that would not have had the opportunity.
Okay. Wonderful, thank you.
So, hi, I'm Elisa Harris from Boston College. And so I just wanted to ask this question. We're talking about social determinants of health among medical providers. So I'm wondering, what can we do to raise this to the larger audience or the public so they understand social determinants of health, so then they can bring pressure on Congress and organizations to help shape policy and change policy. So I'm just wondering your thoughts on that. If anybody thought of that, or what kind of public health campaign we can run, or I just think it needs to be a larger audience. That's the only way we can shape policy and make those changes. So, thank you.
Well, there are a lot of patient groups who are patient advocacy groups made up of people, just regular folk, who are very committed to what you're talking about. And whether we're talking about those who are over 50, and I know there are not many over 50 here, so you wouldn't have gotten your AARP card yet. But that's available to make it a bigger issue, and AARP has a nice way of bringing those issues to the forefront, but it's an exemplar of other organizations that can also do that. So I think it's possible. Part of it is writing for the general press instead of just writing for research journals. One of the things that I loved about Paula's presentation is how accessible she made the research. You didn't have to really stretch and crane your head to the left or right. It was right there in your face, explained to you in a way that you could grab hold of it. That's the way the public needs to receive it too.
I'm Diane Breckenridge, and I'm from LaSalle University, and that is in Philadelphia, Pennsylvania. And I wanted to bring up the points that came forth, and when the doctoral student from New Mexico brought up about students graduating from high school and how important that is for an increased level of health outcomes. It brings back what Dr. Braveman brought up about education, so important for one to move ahead in their career as well as for health. And Dr. Malone brought up about working with the counselors in school and about the health advisory groups and the education advisory groups, not just in high school, but how do we really reach out even to the middle schools, the 5th to 8th grade, so that we can work with our students of underrepresented groups, as well as students who can't even get a textbook or afford to have a spiral, let's say, notebook, and really reach out to those students. I know we all have programs in our states that say health careers and such, but making sure that the tutoring is there. We are doing that in our nursing programs, and we're trying to do that more and more, but how do we do that in our high schools, our middle schools, so that we can really make sure that our students have the college prep courses they need, their ABCs, their algebra, biology, chemistry, to really be successful. I think that's an area that we all struggle with. We've all tried. Many of us work on these different groups, but we have to really even figure out more ways. Do you have any more suggestions?
So let me, sort of broaden out, I think, what you're referring to and what's been talked about by a few of the questions. New Mexico is actually a very good example of this. What we're talking about is a little bit too narrow in terms of an intervention by either a nursing school or any health professional school, or even a HRSA-funded initiative. Those are, if we're lucky, they can be funded for several years. If we're really lucky, we can see some impact from those things, but they don't address, none of those wonderful interventions sort of address the crux of the problem. And the crux of our issue is we have failing structures within this country, and they are, our educational systems is probably the most glaring one, our K through 12 educational system, and our healthcare system, which is why we're going through a reform, is another huge structural barrier to the kinds of social determinants of health or achieving health equity. So if you think about that, and many of you have said that there's a connection between education and health, I think it's more than a connection, I think it's more than a correlation. But if you think about the way our systems are designed for impact, I guess I'll ask a show of hands. How many people here who work at HRSA talked to the education department in the last 5 years? Raise your hand. Okay. Now, what programmatic initiatives do we have combined between the educational system and the HHS, let's say broadly, right? I know they're talking about it now, but we've known that, someone made this comment, we've known the correlations, the connections between these issues, yet we don't have robust innovations coming out of HHS and the education department. Now, that's not to put blame on them, that's not how we work and that's not how we operate. Those are the kind, if we want to see systemic change, we need to have our educational institutions, which are anchor institutions in our communities. Think about a failing community. Think about that picture we saw of that failing community. I bet you in that community there's a university somewhere. So if it's Philadelphia, it's Penn. If it's New Haven, it's Yale. It's Albuquerque, it's New Mexico. These are institutions that are not going to pick up and leave no matter how much that city crumbles, right? The arts institutions within those cities are not going to pick up and leave. They're going to be in those communities. The question is, do they behave like anchor institutions? Or does the cities, the institutions around them continue to crumble? And while they thrive because they have all of the science talent, they get tons of federal research dollars to support them. And so I've been in numerous cities where the teachers teaching science, and I'm generalizing here, either don't have a science degree or are not interested in teaching science. And then I go across the street and there's this wonderful university with all of this science and math talent and acumen there, and it's not brought to bear on that K through 12 system. So until we deal with these, until we recognize two things, there are no magic bullets. None of what we're talking about here is really easy and going to be done, so we don't need to look for a silver bullet because there's no such thing. This is hard work, complex, and requires systems level change. And we can't boil the ocean. HRSA can't put all of its resources in everything, right? We can't, there's no way we can boil the ocean. So until we figure out within that magic bullet, boiling the ocean, there's tons of things that we can do. But it's not at the individual level that the change is going to happen. It's at the systemic organizational level, and we become actors in there. And so my point to you and to all of us that have recognized this broad social determinants of health frame is that until we move from just talking about our appreciation for the complexity and begin to design our interventions with all of the actors that interplay into that complexity, we're not going to have the kind of change that we want. Are you going to make a couple of kids be successful who may not have? Absolutely. But it will take us 200 years before we see the kind of progress that we want. And I guess let me just end with a data point on this. I'm sorry for talking so much about this, but this is what I'm passionate about. Our under 18-year-old population in this country is already at, the majority is already at parity. So everyone talks about 2042, 2050 when the country does this majority-minority flip. We don't have to wait for that, those of us who are educators. It's already at parity. The question is, where are those minority kids going to school? The vast plurality of them are in poor performing school systems. So even though we've reached that numerical parity, will we be able to extract those kids so that they can go on and become the nurses of the future? Not unless we get our institutions to behave differently.
Oh, that's great, thanks.
And as our audience rep, I just want to let people know we have 10 more minutes. I want to encourage people to steer the questions toward nursing in 3D, workforce diversity, health disparities, and social determinants, just to bear that in mind. Thank you.
Okay, Laura Lacey from the University of Missouri in Kansas City. My question relates toward the diversity part of the 3D. And it's a very practical daily issue that we face, and I'm sure we're not the only university. But as we've developed our retention program to really help students from underserved, that are economically or educationally disadvantaged, be successful, one of the problems that we've discovered, and we've added it to our retention program, is that faculty were not taught how to work with diverse student bodies. So we've put in a faculty development program. And as we've gone through evolving what that faculty development program should be, one of the concepts that's come up, and Dr. Braveman, you mentioned it earlier, and it was that of equality versus equal. And we kind of refer to it as being treated the same as not being treated equally. And we've had our younger faculty say, why are you telling us all this? We didn't even know these were issues. And our older faculty are saying, I thought we dealt with this in the 60s and 70s when we did civil rights movement. So this is the one thing that we've had the hardest time getting faculty to put their hands around, is how to manage students differently. And I was just wondering, from an educational standpoint, do you have any strategies or suggestions or guidance on how we work with our faculties to be better about working with different diverse student populations?
So, I think you need to be applauded, because not many of our institutions have recognized the need to either retrain or fundamentally alter the educational process through the faculty members themselves. So I think just highlighting that or spotlighting that is really important, and so kudos for doing that. I think that said, I think that there are some baseline competencies of being an effective faculty member that hold great utility across any students that you're working with. And so the question for me is somebody used, I think it was cultural humility, but I wouldn't limit it to cultural. I mean, I think that I agree it's a fantastic term, but I think, are they humble in their educational delivery, right? Are they compassionate and passionate about what they're teaching, right? And those are competencies that we want for any teacher, no matter who they're teaching. When I think about who's in front of my child, these are the things that I'm looking for. And I think, especially in the scientific realm and in our health professional schools, I think we end up looking so much for the science talent and the ability to get research dollars, which, listen, I know that that's important, and I recognize that that's the model that we're in for most of our institutions, but we have not made co-equal, or it used to be co-equal. I'd say we've diminished it, but it needs to be made co-equal, looking for the compassionate, passionate, humanistic, empathetic faculty members. So I think even as you design with those special nuanced ways of your faculty being able to deal with those individuals, I think we all collectively have to do a better job of ensuring we make co-equal those other attributes that are necessary just to be a teacher.
Yeah, I just want to say, get you a consultant who can go away after they tell them the truth.
We've done that. Now we're trying to move forward.
Because it's the thing is that whoever comes in to say what needs to be said to those folks is going to, you can't do it and stay there. It really is about some self-assessment. And the things that Mark is saying are totally true, but what nurse faculty wants to be taught about compassion? You know, they think it's automatic. Right. They think, oh, of course. So those things, you really need someone from the outside to come in and help your faculty do some self-examination that will not then reside with that coat of many colors on them. You know what they did to that coat. So you need someone to come from the outside.
Okay, thank you.
Okay, so in the interest of time, we're going to have the last two questions. So we want to get those in. So on this side.
Okay, I'll make it quick. I'm Cheryl Jackson from Southern Illinois University of Edwardsville. We have a workforce diversity program. My question is, we see a lot of, if you go back to the saying that Dr. Braveman had up on the PowerPoint, if genetics is the gun and the environment is the trigger, our trigger are social issues. Anything from homelessness to domestic abuse. How do you engage the community, faculty at the School of Nursing to assist these students in finding interventions, strategies, and even resources without destroying the trust that we have with our students? Got any suggestions?
Yeah, so there's a model for this, right? So you guys, anyone familiar with Jeffrey Canada? Harlem's Children's Zone? So this is about, again, you know, it's about structures and systems and to an extent individuals, but it's about adopting areas. Our institutions, our cultural institutions, our higher educational institutions have to say, we are responsible for this particular community. We don't just sit in the community, we are of the community. So we can do all of the small, meaningful, quality, good interventions in the world. To have the kind of change that you're talking about, number one, requires what I think we're trying to do here, which is to fully appreciate the fierce urgency of this moment, right now. And number two is that we are all complicit in this. This is not someone is doing something to someone else. This is all of us who are, you know, working in these institutions. It's up to all of us to push our agencies, our institutions, to behave differently. That's why we're all in the positions that we're in. Whether you're on the front line as a nurse or whether you have become a dean of a particular medical school or you're running a national organization, we all have come to this for the same reason, which is an outward-looking focus on helping our communities become healthy. And my problem with many of our interventions in the past is they have lacked imagination in terms of who should be involved in these collective efforts. We've had success, but it's not as far as it should be by now. We've been doing this stuff for 40 years, and we're still having the same conversations. And the only way to change that, I think, is to bring in these different disciplines beyond the health professions, taking the social determinants of health frame and acting and behaving and certainly speaking differently. But Jeffrey Canada, Harlem Children's Zone, it's being done. And they're modeling this. The education department now is, they have a different name for it, but it's something zones that they're paying. They're doing these block grants to try to model this Harlem Children's Zone so this can be done right in your community. And the nurses are right there with them.
Okay, thank you.
Final question.
Hi, thank you very much. I'm Kathleen Sinkstock, and I'm a senior legislative assistant for healthcare issues for Congresswoman Maxine Waters. And by the way, I'm really pleased to be. I'm really pleased to be here. I'm going to have to leave in a few minutes, but I will be back tomorrow, and I'd be delighted to talk to anybody who wants to talk to me. And I'd also like to thank HRSA for doing this, for bringing attention to these issues, and for talking to the providers about health equity and workforce diversity. I'd like to return to the distinction that Dr. Braveman made between differences and equity. I thought that was a very valuable distinction. And I do certainly believe that we need to study the social determinants and look at the inequities. But I also think that if we see a health disparity, we shouldn't need to justify doing something about it. And I like the example you used of skiers, that skiers have a high rate of broken legs. Well, we don't have to call that an injustice in order to do an outreach to the local ski club and help educate skiers about the prevention and treatment of leg problems. And I think if we see a disparity, for example, in, let's say, the diabetes rates among African Americans, we shouldn't have to justify doing outreach or doing educational programs to address that and do something about it. So if anybody wants to comment.
The issue that would arise would be if the Skiers Association or the what is it, the ones that own the lifts and stuff come and say, I want a lot of money to try to make our slopes, less accident prone, safer for people, and I want to be able to treat people on the spot. It's the competition for resources that sets it up. And I think, as somebody who profoundly cares about equity, you don't have to say, well, nothing else should get any attention. Of course it should, but it's a question of balance and making sure, do we have enough attention being paid to equity on the agenda? And I think you look at the balance books and you can answer that one.
I guess in my situation, I look at this from the policy and the political world, and whenever we talk about racial and ethnic disparities, not just in health, but in just about anything, there's often pushback. Like it's not even a question of resources. Some people think we just shouldn't be talking about it at all. And of course, resources aren't even an issue if we can't talk about it. But I think we need to be able to defend it and say, if there's a disparity, we need to do something about it.
And that the reason is justice.
Yeah, I'm not going to add anything you said, and my colleague said totally enough. I mean, you are on the money. My comment, it has more to do with an error that I made. When I was speaking, I said that the NurseFamily Partnership was in 49 states. I was really thinking of the regional action coalitions of the RWJ that are in 49 states. The NFP is in about 31 states, so it's still got quite a few to go, and I just wanted to make that clear.
Thank you. I'd like to thank all the members of the panel, and I'd like to thank all of you. Thank you. So I think, Patrick, are you going to tell us that we have a quick break?
Yes, thank you, Dr. Bakos. And thank you, Dr. Bakos, Dr. Nivet, Dr. Braveman, Dr. Malone. And we so much appreciate this incredible panel from our expertise, the folks in the audience, as well as the tweets. And we'll see you in 15 minutes, folks, okay? So please take a break, and we'll see you in 15.